مساء الخير, Assalamu alaikum. I'm very honored to be here in DIA Egypt 2020. It's a true privilege, and I would like to thank the organizing committee, and I would like to thank Professor Khalifa for the kind invitation. I was asked how to assess the cardiovascular status for the diabetologist. Some of the opinions expressed are my own. They don't necessarily reflect the guidelines. Please challenge them at any point, and I have no conflict of interest with this presentation. Recently, there has been some changes in the scene of treating cardiac diabetic patients, and we should work in a multidisciplinary way instead of having a turf war. After the introduction of diabetes drugs with cardiovascular benefits, there have actually been many calls for the cardiologists to treat diabetic patients using the SGLT2 inhibitors and the GLP-1 agonists. And in the cardiology community, diabetologists are actually often criticized for not giving guideline-based statin doses, for not using enough ACE and ARBs in patients with albuminuria without hypertension or with hypertension. So it really is time to work together for the sake of our common patients, and that is the only way forward. And today we'll highlight what the diabetologist should know on the cardiovascular assessment. Actually, the diabetologist is a much more important doctor than the cardiologist, because as long as the patient does not have an acute event, he doesn't really need his cardiologist, but he'll always be with his diabetologist. And his diabetologist should be able to take him from A to Z without referring to a cardiologist. It should be the other way around, because diabetes will actually hurt and kill your patient via its cardiovascular complications. And as a diabetologist, you need to know about the cardiovascular complications of diabetes more than the cardiologist needs to know about any aspect of diabetes, including the novel therapies. So I'll go very briefly in the most recent guidelines that we have for cardiology, but I'll just mention things relevant to diabetes. And these are the 2019 guidelines of both the American College of Cardiology and the American Heart Association. You know the level of evidence, which is class 1, 2, 3, and also level of evidence A and B, NR with trials or just expert opinion, and level of evidence C, which is the expert opinion. So the top take 10 messages are: the most important way to prevent atherosclerotic disease, heart failure, and atrial fibrillation is actually to promote a healthy lifestyle throughout life. And we believe that this is the mission of both diabetologists and cardiologists, but probably patients don't see cardiologists early in the course of their disease, but they do see the diabetologist. And the diabetologist's most important mission, number one, is to promote a healthy lifestyle. There should be a team-based approach to take individual patient decisions, well-informed. Adults who are 40 to 75 years of age, when they go to their diabetologist, they should undergo a written 10-year atherosclerotic cardiovascular risk estimation. The tool is actually on my iPhone, and on any smartphone, you can just download it, ASCVD, it's called, atherosclerotic cardiovascular disease. And it takes you 1 minute to put your patient's data, and it'll give you the patient's risk score. If you don't know what's your patient's risk, you will just wait for things to happen. And that is more important than any form of screening. It's more important than CT angio. It's more important than doing even a coronary angiogram. We should talk to our patients about diets, and we should also give it to them in writing in very clear form in their language. If we don't talk to our patients about what they should eat, we're doing something wrong. We should let our patients, especially our diabetic patients, and this is top 10 messages, all class 1A, engage in 150 minutes a week of moderate intensity exercise or 75 minutes of vigorous intensity exercise. Adults with type 2 diabetes should receive lifestyle advice as improving dietary habits, exercise recommendations. For them, this is more crucial than for non-diabetic patients. I'm showing you again the guidelines of cardiology. And the guidelines of cardiology is saying if a diabetic patient is going to take a medicine, They should take metformin as a first-line therapy. If it's not enough, and the patient is a cardiac diabetic patient, then a consideration of an SGLT2 inhibitor or a GLP-1 receptor agonist is indicated. And how we should do that is we should actually call the diabetologist and ask them to kindly incorporate this in their treatment if their patient is a cardiac patient. All adults should be assessed at every single visit with tobacco use, and those who should use tobacco should be strongly advised to quit and should be helped professionally. Aspirin should not be used in primary prevention because it does not work and should be used very rarely by diabetologists, to be honest. Cardiologists will use it in secondary prevention. Statin therapy, I won't go through it, but it has to be used in all adult diabetic patients to a high intensity, bringing their LDL below 70 or even below 55. And of course, diabetic patients in particular, the target blood pressure should be less than 130/80. 140/90 is too much. If you want to measure the calcium score in your patients, which is sending the patient to do a CT without contrast material to know if they're atherosclerotic or not. You can do that even in patients with metabolic syndrome who are not even diabetic. If the patients are reluctant to initiate statin therapy, or they have side effects and you want to know whether you should give them or not, or they're old with low risk factors, or they're middle-aged adults with an estimated moderate cardiovascular risk of 5 to 75%, you can actually do a calcium score because this will help you decide if you want to give statins or not. This is for non-diabetic patients because all diabetic patients should receive statins anyway. In adults with type 2 diabetes and hypertension, we start drug treatment earlier than other patients. We start at 130/80 instead of 140/90, and the treatment goal is less than 130/80. Aspirin shouldn't be used. There have been trials about screening all patients, all diabetic patients, with calcium, with CT angio to see if this will help. This is a famous Intermountain trial where, because we know that coronary artery disease often is symptomatic and the patient might get a myocardial infarction and death, so theoretically they thought, does this justify routine screening? And of course, a coronary CT angio shows you everything. It shows you, it's like a started ALB, non-invasive. It shows you the extent and the severity. And this trial assessed whether routine screening for coronary artery disease by CT angio in higher risk patients with diabetes, but who are asymptomatic, followed by CT angio-directed therapy would reduce cardiovascular risk. I don't want to take you through it, but actually it did not work, okay? So among the asymptomatic patients with type 1 or type 2 diabetes, screening for coronary artery disease did not reduce the composite endpoint of all-cause mortality, non-fatal MI, or hospitalization, despite those patients actually received more treatment and better lipid control and better blood pressure control. And the reason for this, because the annual rate in both arms was less than 2%, the event rate. So basically, the patients who were not screened were so well treated, because this is a very, the enrollees of the Intermountain Healthcare, which is a big American healthcare system, were so well treated that the event rate, even in those who were not screened, was so low that the findings do not support the routine screening. So actually cardiac imaging in an older ADA statement was looked at in every single way. Exercise was studied, exercise plus adenosine, dobutamine, dipyridamole dobutamine, and for long periods of follow-up to screen diabetic patients. Exercise in more studies by Hany et al, dobutamine, so many studies. And even calcium scoring, nuclear imaging, everything was done. And the conclusion here was that SPECT imaging did not work, but that there was an advantage for anatomical testing is that both obstructive and non-obstructive clinical coronary artery disease actually can be visualized, and this allows detection of atherosclerosis at an early stage. However, after you detect atherosclerosis at an early stage, what should you do? So you have an asymptomatic patient, and you do a CT angio, and you see a plaque in their LAD. What should you do? I'll discuss this with you in a minute. But actually, if you were treating your patient to the guidelines, as I showed earlier, it shouldn't make any difference, because you're basically bringing their LDL down to 55 or less. You're giving them ACE inhibitors for to protect their kidneys. Maybe you'll give them aspirin or not, probably not. So the information is there and is very useful, but we don't know what to do with it once we get it. So the best thing to do is to treat all patients well, and then you don't really need to screen. Again, there was a lot of studies from Korea, the DIAD 1, 2, and 3. I don't want to, for the sake of time. They showed again, all arms, the imaging and the non-imaging, nuclear imaging or non-imaging. Both arms had very low event rate, so again, the study was futile. And there was some benefit to screening for some patients, but routine screening was not recommended. This is what you should do if you use a calcium score. If the calcium score is less than 100, do not do myocardial perfusion imaging. If it's between 100 and 400, and your patient is diabetic or has retinopathy, microalbuminuria, or diabetes more than 10 years, then you should do myocardial perfusion imaging. If it's more than 400, do a myocardial perfusion imaging anyway. So this is a good algorithm if you want to study. So what about echo and heart failure? Because many diabetic patients are in heart failure. Some of them are in clear heart failure with a low ejection fraction, what we call HFrEF, heart failure reduced ejection fraction. But the majority of diabetic patients who are in heart failure actually have heart failure with preserved ventricular function, what we call HFpEF, heart failure with preserved ejection fraction. So who needs an echo and who needs natriuretic peptides, NT-proBNP? And when should you order an echo, and what should you do when you look at an echo? We should be aware of the different stages of heart failure. There are mild heart failure, there's severe heart failure, there's heart failure with reduced ejection fraction and with preserved ejection fraction. The new methods of measuring cardiac contractility, which is the strain rate, the global strain rate, longitudinal strain rate, will show you subtleties. So a patient might have normal ejection fraction, but abnormal strain. And I would recommend that you just go online and in 2 minutes read about the strain rate. What about using biomarkers, which is completely underused in Egypt? What is the BNP and the NT-proBNP? They're actually proteins released by the heart when the pressure in the left atrium is high. So if you have a high left ventricular end diastolic pressure, the left atrium stretch receptors, and if you have some, will actually release those hormones. And if they are levels low in blood, less than 100 for BNP and less than 300 for pro and TBNP, the patient does not have heart failure, even if they have dyspnea. If they are high, it really helps to diagnose. And these are the cutoff points. In BNP, it's 100 or above 500. In the middle range, you have to look at it. For NT-proBNP, it really depends on the age. In age above 75, you can accept up to 1800 without heart failure. Anyway, if it's less than 300, you rule out heart failure. And diabetologists should screen their patients who are at risk of heart failure, the elderly, the ones with atrial fibrillations, the ones with dyspnea, without the need for a cardiologist using the biomarkers. You don't need a cardiologist. My last 2 slides. Optimal medical treatment is the key to management. If we manage our patients optimally in every single aspect, in statins, proper hypertension medication, those who need aspirin and those who don't, know everything. If we give them exercise, if we show them how to lose weight, if we make them stop smoking, screening becomes much less important. We've seen big studies which the control arm was very well controlled. Screening was useless. We should know about it, but it's not important. Prevention of cardiovascular complications for diabetes is much better than trying to detect them later and should be rigorously pursued by every diabetologist. It's as important as diabetes, as hemoglobin A1C control, including lipids to target, evidence-based control, and lifestyle modification. Using calcium scoring and CT is useful, but not routinely indicated, but in high-risk patients you can do it. For those with highly abnormal imaging, you can do a stress test or a stress echo, but it does not affect the outcomes. This is my last slide. Diabetes and heart failure coexist, and they both make the patients die. So a diabetic patient will die much worse if he's in heart failure, and a heart failure patient who develops diabetes will also die. So diabetologists should be competent in echo. They should know what's an echo with a normal ejection fraction, mid-range ejection fraction, or low ejection fraction, and also in minor valve lesions, and also in using the biomarkers, the BNP and the NT-proBNP. Just out of curiosity, in the last month, how many patients did you refer for a BNP or an NT-proBNP test? A show of hand. Okay, we're three people in the room. Everybody in the room should have been doing this. So this is, it's something we're learning to do. I wasn't doing it last year. So please just read about those tests and see how you can use them, because you don't even need a cardiologist. You don't need somebody to interpret the echo. It's just a lab test. Again, I'm very honored, and thank you very much, and I'll be happy to take questions later.